Welcome back to the Life Support Podcast. Thanks for listening. This week, we talked with Sabrina and Tyler about pharmacy and how everything I thought about pharmacy was wrong, including the fact that they can actually escape from behind the glass at Walgreens. Before we get started, just a quick reminder to hit that subscribe button wherever you get your podcasts. Enjoy. Hey, Sabrina. Hey, Tyler. Thanks for talking with us today. Could you just start off with an introduction? So we like to include name, pronoun, where you're from, what you do when you're not working first, and then what you do when you are working.
Yeah, hey, I'm Sabrina Sherwood. I'm a clinical pharmacist in Boise, Idaho. I work at the Cystic Fibrosis Center of Idaho, here really close to downtown St. Luke's. And in my free time, I love to go hiking, spend a lot of time in the foothills and up in Stanley, Idaho.
And my name is Tyler Hemsley. I'm a pharmacist by training as well. I've spent most of my career working for St. Luke's Health System here in Boise and in Twin Falls. And then recently I've transitioned over to Cornerstone Whole Healthcare Organization. So I'm part of CHU. Currently work as the COO over pharmacy and healthcare innovation. And so we're doing a lot of exciting things with pharmacy integration and collaborations with behavioral health and team-based care, and we get to dabble in a lot of very cool projects with CHU. So that's been really rewarding. Outside of work, I like staying active. We do a lot with the family, just kind of getting out and getting into nature, going on walks, things like that. I'm a huge muscle car fan, and so I have some projects and things on the side with some automotive interests as well. That's me.
Very cool. Very cool. Well, thank you guys again for joining. And I heard you say some words that I wouldn't necessarily associate with pharmacy, because I think when most people think pharmacist, I think that the general population thinks of the person really in the white coat behind the glass at Walgreens. Can you tell me I'm wrong and why I'm wrong?
Yeah, I would say that you have two good examples of not the white coat behind the glass. One of the things that has happened over the last 30 years, I guess, in the pharmacy profession is there's been a really significant evolution from kind of that mom and pop soda shop, right? Where you have the soda fountain and the pharmacist is behind the counter and, kind of compounding, powders and packets and pills and things like that. And over the last 20 or 30 years, we've really seen a significant shift in both the education as well as the role and responsibility that pharmacists have. And that has evolved not only in the context of clinical pharmacy, but also in the context of what community pharmacies and community pharmacists can do from these locations in the community with the strong ties that they have with their patients and population. So, and not to mention everything that goes on in the hospital as far as really kind of specialized intensive care or cardiology, telemetry. There's a lot of pharmacists that work in pretty specialized units in the hospital. But that's a very broad sweep. And then Sabrina, I'd maybe put you on the spot to dive into a bit more detail.
Yeah, absolutely. I think it's such a great question because I get questions about pharmacy multiple times a month. And, it's funny, every time I see a patient in the cystic fibrosis clinic, it takes a few interactions for them to fully understand what we're doing here in clinic, right? Because they're used to seeing that face behind the counter at Walgreens. And so it is really interesting, like Tyler mentioned, the evolution of pharmacy. And I think teams are starting to see, that includes providers, other staff members, they're seeing that pharmacy can be this physician extender where we're really focusing in on those clinical aspects that we're so good at, right? You think of pharmacists, you think of detailed. We're really good at catching the details, but we're also really good at education, right? We do medication-related education all the time. And specifically, the residency programs that are now being developed for pharmacy are just taking pharmacists to the next level. So we have 1 or 2 year residency programs that you can do right after school that help you specialize into different areas of pharmacy. So we've got, acute care pharmacists where you can really spend time diving into an internal medicine team or other acute pharmacy areas like oncology. We've got oncology pharmacists who operate inpatient and in the ambulatory care setting. We've got a general ambulatory care residency. And then also, like Tyler mentioned, lots of community residencies, ways to basically take our retail pharmacists and help them to do more than just that typical what you think of counting pills, but they're really offering services at the pharmacy level to elevate patient care and hopefully impact those outcomes that we care so much about, which is making our patients healthier. So that's a really broad overview of kind of what pharmacy can do nowadays, but it's great and it's expanding every single day. We've got tons of board certifications available and just so many options to specialize.
The other thing I really didn't mention is the complexity that we've seen within the medications. So I was in an amazing conversation, I think just last week, but we were looking at the timeline of just not that long ago was when we got penicillin. In the scheme of things, that wasn't that long ago where penicillin was kind of the drug. We had maybe a handful of other things that could be used as medications at that point, but there really weren't that many things. And because of that, and because of the subsequent drug development, and because of the subsequent research and development that happened within the pharmaceutical industry, medications and the myriad of ways that we have to approach chronic disease has exponentially gotten more complicated. Along with that, we've had an incredible shift to insurance coverage of medications. And so with that, it used to just be cash. And this is, again, in the 90s, you didn't used to have a pharmacy benefit card, right? It was always just you paid cash for your medications. And then we started to have it overlaid with the complexities of insurance. And most of the significant pain points that we see as it relates to medications have gotten so complex that you really need an expert in this area. You really need someone who speaks the language. You need someone who understands the right questions to ask, the right processes to follow in order to navigate these what have become pretty difficult waters. You just can't write a prescription and anticipate that it's going to be covered anymore. It's sadly, there's a lot of complexities as it relates to cost and prior authorizations, and really having a pharmacist and highly trained pharmacy technicians in this area can really streamline access and open up doors for patients and limit financial toxicity in really meaningful ways. So just a few of the things that over the last 30, 40 years, we've seen pretty dramatic shifts in who the pharmacist is and what we do.
Wonderful. Thank you so much for that explanation, because I think that it really shows, like you said, that progression, like that person behind the soda counter that has 4 or 5 bottles that they're handing out for, every condition under the sun, to just this immense world that intersects with like economy and chemistry and medicine and all of these other sectors. So I love kind of that vision of, okay, we've done this sprint from recent history to really changing the way that we think about and can engage with pharmacy as patients and as healthcare systems. As we dive a little bit deeper into maybe some different roles of pharmacy than what people might think, like for a retail pharmacist, can you walk me through how a pharmacist might work in a primary care clinic supporting depression management? Can you walk me through what a patient might see in working with a pharmacist there?
Yeah, absolutely. I can take that one. So I'll give you a little bit of background. I don't work in a mental health clinic, but I do work in a cystic fibrosis clinic, and I'll give you kind of the general layout of how it works to integrate my role. So in the cystic fibrosis clinic, we have multiple members of the care team. It's a very interdisciplinary ground for amazingness, I would say. That's not a word, but it's wonderful. We have RTs, we've got dietitians, we have school counselors, we've got all sorts of members of the team to help really provide a comprehensive service to our cystic fibrosis clinic. So when I started this role about 4 years ago, really developing this pharmacy program at the Cystic Fibrosis Clinic, the question was, well, how are we going to integrate a pharmacist into the team? What does that look like on the day to day? So, what we ended up with after a lot of different trials was having the nurse see the patient. So, they room the patient. I go over the medications and any allergies that the patient might have. And at that time, I do a comprehensive medication assessment. And so that would include drug interaction checks, that would include education on new medications that they've recently started or we've been talking about starting for a while, especially in cystic fibrosis. We have lots of very expensive new medications coming out that I help patients understand on how they work and how to take them appropriately. And then a lot of cost access issues. We do a lot of things related to medication cost and helping patients afford the medications that they're on, right? Because we know that's a huge barrier to patients successfully taking therapies. If they can't get the med, they can't take the med. That's kind of my role within the cystic fibrosis clinic. And after that, then I'll pass off to another team member, and then we'll do kind of a team-based staffing on the patient so that we're all on the same page and we can make recommendations that are really efficient for the patient. Now, when you talk about different specialties, I think that groundwork really applies in every setting of pharmacy. So, if you're talking about a depression related kind of role, I think that MedRec is so important. A pharmacist is so good at looking at a medication list and being able to really clean it up. I would say within my first year or two of being in the clinic, I spent a lot of time just cleaning up medication lists because it's amazing how, they can become so big and you learn that patients are not really taking all of these medications or some of these medications are not needed anymore. So it's nice to clean that up. And then, specifically, we talk a lot about drug interactions. For antidepressants, there are so many out there that we can choose from, and helping patients select the right one for them that's going to match kind of that side effect profile that they're most okay with is really a value add, I think. I don't know of a lot of physicians that have a lot of time to spend with their patients to really dive into those specifics. And so what I like to do in clinic is bring them a literal chart of the different SSRIs and say, all right, let's look at these side effects. What's going to fit for you? Like, are you needing to sleep more, less? What's going on? How is your GI tract already? What can I do to minimize any side effects? We can also do cross tapers on antidepressants. And I think one of the coolest things is that we're really good at follow-up. So if you need somebody to follow up with a patient after you've seen them in clinic and then report back to you of how they're doing, pharmacist is really, really great for that.
I think that was going to be my main point right there. And you nailed it at the last part is like access and follow up. Usually with medications and usually with the way a traditional primary care clinic is run, it might be 3 months or it might be 6 months before a patient can get back in. Ideally, we would like to see them back in a month, but a lot of times that becomes problematic or we don't have the team to support that kind of rapid follow up. I think that's been one of the main things that we've seen with pharmacists in a primary care setting is the flexibility that that provides the clinical care team for delegation. And so quarterback or the primary care provider can hand off to the pharmacist. Pharmacist can then take over treatment for a while or follow up. They can adjust medications, especially in the setting of antidepressants or anti-anxiety medications. This is a fine tuning process, right? And it's well within the scope of our training. So pharmacists are pretty extensively trained on kind of the core disease states between, metabolic conditions like diabetes and hypertension and hypercholesterolemia, but also general mental health. So anxiety, depression, things like this are things that we've been pretty extensively trained for. And managing the medications and understanding the side effects and understanding a lot of the reasons that patients might not engage or might not take medications is something that we're really well prepared for. And so working as part of that team, going from the initial diagnosis to initial treatment strategy to follow up to navigating any cost concerns, navigating any side effects once the medication has been started, helping patients understand the timeline that it might take for them to see an effect, checking back in on the patients, working with the care coordinators or the other members of the care team to make sure that that we have folks docked into the right resources like counseling or behavioral health if that's available is just a wonderful example of how pharmacists can kind of round out that care team and that team-based care approach.
That's super interesting. I mean, I guess y'all are making me think about how, especially in, modern medicine, oftentimes, almost all the time, treatment is a prescription or is a medicine. And, that relationship between a patient and the provider is often a relationship of medication management, but access to that provider can be so low. So when you think about adding in that pharmacist, how that medication management and support can be so beneficial, it seems like, and helps open up that access so people don't feel like they have to do it on their own. I just think about, I've had family members that are like, well, I tried stopping this medication or I tried doing this, like people kind of acting as their own providers or their own pharmacists. Is that something that you see as a role for pharmacy, as kind of stepping in and saying, hey, you know your body, but we're all to the pharmacist. Let's help you walk through this, right?
Well, you raise a really interesting point about the relationship between the patient and the provider. And one of the most interesting things in the course of my practice and experience over the last 10 or 15 years has been when you involve a pharmacist on the care team, a lot of times the patients are more willing to dive into details about the problems that they're having with their medications, or that they can't afford their medications, or that they're giving them side effects that they really can't tolerate. They don't want to disappoint their physician because their physician was the one that prescribed this medication as the way that this is going to heal me. And yet I'm struggling either to afford it or to take it on time, or there's a myriad of things that can get in the way. And for some reason, incorporating the pharmacist is like, hey, we're here to talk about your meds. It opens that door to help patients feel a bit more comfortable saying, yeah, I stopped taking that 3 weeks ago, or I just doubled my dose, or I thought I was supposed to take 2 pills 3 times a day. And all of a sudden we can unwind a lot of these challenges. And then when we come back and download all that information with the provider, a lot of times it's just this, amazing patient care moment because the provider had no idea that they doubled their dose or stopped taking the medication or couldn't afford it. And then all of a sudden now we have ways to solve these problems together as a team and get the patient access to the medication that they need. And I just countless examples of where that initial conversation with the pharmacist has then allowed the team to take better care of the patient.
Absolutely. And I'll just add that I see that every day. Here in clinic, it's very clear that the relationship that the pharmacist has been able to build with the patient goes so far in this holistic view of their medication and their treatment of the disease state. I think about adherence and how a lot of our patients are really struggling to be adherent to their medications lately after COVID and with the advent of these really highly effective modulators. It's really hard to convince them to do hours worth of inhaled treatments every day, right? We have a really good relationship with our patients where I spend that time to get to know them. I know their dogs' names, I know their kids' names, and that really goes a long way. And it's something that not everybody has the luxury of doing, but it also makes for very good conversations about adherence and how we can improve that. It also, an example is a lot of times I'm the first one to know on the care team if one of our patients is pregnant because they're calling me to ask about medications and what kind of interactions there will be, what they shouldn't be taking, things like that. So just to Tyler's point that there are a lot of examples of how having that pharmacist on the care team can really help with all things medication related.
Medication, potentially other treatment related, right? Like you talk about pregnancy. All right, here's a whole nother line of care and treatment that we need to go down. So I think that makes sense. And it seems like once you guys are talking about this, that there's that pretty easy pathway to have that conversation, relationship, and disclosure, whether it's side effects or symptoms or affordability, to have this really holistic care around a patient when you talk about their medical provider, their pharmacist, and other parts of the care team. So, but again, we've come a long way from the white coat at Walgreens, right? And what I think most people think about in terms of pharmacy. So as we've been talking, like it's very clear that pharmacists have a major role to play in clinical care, not just kind of dispensing medications. Um, Although that's hugely important for pharmacists that do fill that role. The other thing that's come up a lot in this conversation is cost, and you don't really think about it that much, but we hear all the time about like the cost of medications, the cost of care, people going to Canada to get medications. Like you said, people having to choose between keeping their lights on or paying for medication. So obviously, this is a huge issue. What role can pharmacists play in managing costs for individuals and costs for systems?
I think cost of medications is a huge challenge that we face in the United States healthcare system at the moment. And there's a lot of complexity here, because what drives price and what drives the FDA approvals and pipeline and drug development and research and all those things, to simplify it would not do it justice, right? The way that I have seen pharmacists involved in this broad landscape is to really help inform, talk through the evidence, make things as objective as possible, really try to highlight the value proposition associated with a new medication, and figure out how we can help position that medication the best way that we possibly can as it relates to coverage, as it relates to patient out-of-pocket expense, and that plays into affordability and accessibility. The other thing broadly I would say is that a coordinated approach to this process is absolutely vital. You really need an understanding of, especially as we get into these medications that are astronomically expensive for rare disease states. You're talking about medications that are $35,000 per month. Sometimes in the course of a treatment, we've got $1 million in medication, and that sticker shock. I don't know that we've really wrapped our minds around the total cost that we're dealing with in these situations. But with these specialty pharmacy medications, it absolutely needs to be a coordinated approach between the pharmacies, the pharmacists, the specialists, the patient, the care team, so that we're using these medications as judiciously as possible and as effectively as possible. And that includes like the monitoring and the follow-up and making sure that we're discontinuing medications when it's appropriate to discontinue, that we don't just keep going down a path where we're essentially losing efficacy. There's a point of diminishing returns. Or if we need to switch gears and change to a different medication, we need to do that quickly so that we don't just continue to spend really valuable time and resources on medications that are going to be less effective. So it's a very, very complex situation. But pharmacists have been able to fill roles at payers and formulary development and formulary monitoring and helping health systems and specialty clinics, kind of from very broad strokes all the way down into the very granular operation, make best use of these medications. So, and Sabrina's a good example of kind of the team on the ground that deals with this every day.
Yeah. So from that perspective, it's really interesting. Pharmacists are in such a unique place to have an impact on cost. So, thinking about kind of the cystic fibrosis clinic and how I'm tied in, um, I have the collaborative practice agreement to be able to prescribe medications through the cystic fibrosis clinic. And I can literally watch that prescription go from the second I write it to the second it's sent out the door to be delivered to the patient. I have the ability to have my hands on every step of the process. And so having that insight and understanding of how adjudication works, uh, as in how we can bill the medication to the insurance company, allows me to have that intervention quicker to be able to reduce costs. So from the second I send a prescription, I can tell, is this the most cost-effective therapy? Is this what the patient really needs? And then, down to the $30 copay that our patients cannot afford sometimes. I can help them navigate grant funding. I can help them navigate any copay cards or manufacturer assistance that's available. And for our patients and a lot of patients, it's sometimes the decision of a $30 copay or more groceries. And so that's something that we really help navigate and help minimize. I think there's also added value in pharmacy that we're beginning to really show is this invaluable resource of adherence, right? So for cystic fibrosis, showing a greater than 90% adherence to some of our therapies reduces hospitalization risk by 70%. And so that's a huge deal when you talk about money saved. And of course, you have to kind of weigh the cost of the therapies with the cost savings of a hospital admission. But for some of our patients, it's a no-brainer. They're getting admitted, every 6 weeks, and you're reducing it to twice a year, maybe. It's just huge. It's a huge impact. So that's kind of the operational day-to-day way that we can impact cost.
And it seems like that's influencing the system totally across the board in a net positive way. That's at an individual level, at a cost to the health system, and overall quality of life. So I don't know. It makes me think my 4-year-old son is into playing like good guys, bad guys games right now. And I'm just thinking bad guys, Pharma Bro, good guys, Tyler and Sabrina, and all the other pharmacists out there. So you said it was complex, Tyler, but I'm just going to ignore that and distill it down to good guys are the pharmacists helping us control costs. That's
I think
fantastic.
there's
So,
definitely been some examples of bad players out there, right? And that's one of the things that I think is challenging within a lot of different aspects of healthcare is what gets on the news or what gets held up as an example, especially as it relates to, drug pricing and manufacturers and PBMs. And there's so many factors at play here, and it has become um, a political game as well. And so you're going to get some mudslinging in that arena.
no, and I think you and I have had some of these conversations before where there's like what you can do at the clinical level, and then there's also like pharmacy policy, which is a huge space. So
Uh,
I don't think we're going to get too deep into that today. That would be a great another conversation. But thinking about that, sometimes these are levels of interface or interaction at the patient level, and then sometimes it's at the state and federal level that's really making a difference in terms of access to medication, which is access to treatment for the majority of patients that are being seen in a healthcare system. I guess one thing that brings up for me is thinking about, these models of integrated pharmacy. Um, you sold me in terms of the value. Um, it seems like the bigger systems in urban areas and population centers, as always, will have more access. What does implementation of this model or access look like in rural communities where you might have one or two medical providers
but
or a very small hospital? Is this feasible for them?
yes, it's just about right sizing the resources. And so what we've been able to do on a few different projects is in these very rural areas, sometimes it's a matter of finding allies and community players or community partners. And maybe there's a local independent pharmacy or a small primary care clinic that would be willing to work with each other. And so maybe the clinic can't afford a full-time pharmacist. And that's understandable. And maybe they don't even need a full time pharmacist. Maybe they could use a pharmacist a half day a week. Maybe the pharmacist could support remotely. So we can do a lot with kind of hubs and spokes. And so it might be that in a urban setting, you might have need for a whole team of pharmacists and pharmacy technician extenders, but that also creates the opportunity to do some really amazing peripheral support and outreach, sometimes via telehealth, sometimes just via remote support via an EHR. Or there's a lot of flexibility. I think one of the things that we have not explored completely because of the concerns we have around compliance and information sharing and things like that, we always err on the side of, of compliance, especially as it relates to PHI and HIPAA. But I think those regulations were put in place to actually facilitate better coordination between healthcare entities and not to put walls between healthcare entities. And so as it relates to collaboration within a healthcare neighborhood, I think there's a lot of untapped potential to put the appropriate paperwork in place that, identifies the relationships and everything. But I have seen, especially in rural areas, where pharmacies and clinics can coordinate and communicate and improve the care for their patients in really innovative ways without having to break the bank, and say, gosh, we're going to need $500,000 and a new building. And it's really not that difficult to implement these services. You've got to do some, really basic analysis to figure out what your resource need would be, and start small. That would be my suggestion. Is if the initial position is, part-time, half day a week, there's going to be ways that you can just incrementally build into something pretty special.
Yeah, and I don't have much to add, Tyler. I think you really captured it. I'm really excited to see our community independent pharmacies grow and see how they can hopefully evolve over time as we're learning. I think a lot of independent pharmacies are looking for that next step and seeing how they can kind of connect more with their community and have an impact on those patients that they know so well. They have such a good relationship, going back to what we were talking about earlier with, sometimes they're the first to know about things going on in their patients' lives. So I think they are really positioned well to have a huge impact.
I love that. And it makes sense too when you think about rural communities, where there might be that closer relationship or that more personal relationship between a pharmacist and a patient. It's not, going through the drive-through at Walgreens, plugging in your information and something going through the pneumatic tube to you. It's talking about what that medication is, catching up on personal things. And so really getting back into some of that model that you guys have talked about with integrated pharmacy in the clinical setting. Probably some of that is happening within those community pharmacies, is just about like setting that up so that there is more partnership as a care team with that patient, the pharmacist, and the medical provider. So I absolutely love that. And sells me on the idea that this isn't just for big hospital systems. We love our big hospital systems, but that's not where everybody gets their care. So I think that's encouraging and fantastic. Anything else that you want to share with us before we sign off on this conversation?
I would just say that I know we've talked about kind of the Walgreens model or some of the big chain stores. I want to emphasize that the practice of pharmacy, even within the context of these big chains, has evolved significantly over the years. And a lot of times that pharmacist is identified as one of the most trusted members of the care team, even though we don't have the best of communication lines between maybe that pharmacy and the clinic. Pharmacists in the community setting, I think, have an incredibly untapped potential to be a greater part of this broader health neighborhood, including the chains. And I realize some of the corporate structures that we have that restrict a lot of innovation because it's just the nature of the business. We see it with, larger health systems versus independent primary clinics and larger drug chains versus independent pharmacies. And it's kind of two sides of the industry that I think there's advantages and disadvantages in both areas. And so, especially as it relates to the rural and frontier communities, I think, Rachel, you said it very well. Sometimes the independent community pharmacy is one of the only healthcare providers in the county. And so they may have a very close relationship with their pharmacist. They may see them at the grocery store. They may go to church together. We're talking about a tight-knit community where you already have a lot of trust and a lot of what we talk about on a national level about insight into social determinants of health and how do we know if, they have food insecurity. And these are the types of communications that I think in these rural and frontier settings, it's part of understanding who your neighbor is and who you're rubbing shoulders with at the pharmacy and the clinic and the community center. And it for me, this is a really powerful principle of communities starting to take care of each other and watch out for each other and becoming a more tight-knit group as it relates to our health neighborhood. And anything we can do to improve those lines of communication and collaboration, especially amongst like clinics and pharmacies and behavioral health providers and the counseling center down the street or the community center with the Boys and Girls Club or things like that. I think this is all moving things in the right direction. And so we're just happy that we had some time to kind of talk through a lot of what we're passionate about today, and how pharmacists can play a role in that work.
Fantastic. Well, I so appreciate that. And I also appreciate the call out that those retail pharmacies, your Walgreens, Walmarts, big guys aren't the bad guys. As somebody who's 4'11", sometimes like I have this complex. No, but I think it's so helpful to think about everybody as being in this partnership model to really help patients. And that historically pharmacy hasn't been at top of brain for a lot of people in that model. So I love that you're elevating that and sharing that. And sounds like we got a couple of follow-up conversations to have. Hot button politics of pharmacy. I don't know. Maybe get a bonus episode on how to get my toddler to take her ibuprofen when she has a fever. I've got so many more questions for you guys, but I so appreciate y'all taking the time. Thank you for the work that you do. And thanks for sharing with our life support listeners. A big thanks to Sabrina and Tyler for their time. Thank you to you all for listening. And please subscribe and remember to provide each other a little life support. Life Support is a podcast developed by Sihu, where we talk to providers, experts, and others about their experiences with health and the systems that create it. This podcast music is written and performed by Anthony Leon. The show is also produced by Anthony. For more information, visit us on the web at sihu.org and remember to follow us on your favorite podcast app. Thanks, everybody.